How was everybody? You all get my announcement? Okay. So don't forget, this evening by 11:59, you have quiz number one, pre-quiz number one. So if you've come to lecture, you've done the readings, the pre-quizzes should be very straightforward. Okay. The post-quiz due Thursday, there's probably going to be one or two stretch questions. Stuff that we didn't cover, stuff that you might have to look up online. Yeah, you can, chat GPT it, see how it helps. But it's pushing you to try to synthesize information on the post quiz Thursday by 11:59. Okay, I'll remind you in lecture on Thursday as well, just so that you don't forget. So according to my notes, this is where we left off. But before we go there, what kind of shoes do frogs wear? Open-toed sandals. No? Okay, tough crowd. I just built an ATM that only gives out coins. I don't know why anyone hasn't thought of it. It just makes sense. No? Boom. Okay. Did I ever tell you about the time I went mushroom foraging? It seems apropos for Flagstaff. No? It's a story with a moral at the end? All right. This is a really rough crowd. You guys are the rain, the weather's got you down. So I don't know what else to help you with. I gave you some of my best material, and it's just not satisfactory. So I'm going to have to wow you with cell injury. How's that? Because this is electrifying. It's actually kind of cool when you think about it, in a nerdy kind of way. All right? But let's be honest. There's a lot of nerds in this classroom, right? You don't have to raise your hand. We know you are because you're here. Because you only take this class if, you're kind of a nerd. So that's good. So let's talk a little bit about the types of things that cause injury to a cell. And, I've shared with you that the cell is under constant stress. And we're going to look at today very specifically. We're going to dive into very specific examples. It's going to be a little heavy today. We'll get into some of the mechanistic pathways. It's one of the reasons that we record the lectures. So if you're kind of falling behind, you can kind of go back and be like, I just don't remember those different types of necrosis. I need to refresh my memory. Is everybody finding the YouTube site? I try to put the link in the announcement. Did it work? You should just be able to click on and it goes, right? But I'm getting out of that age now where, like, when my iPhone doesn't work, I have to call my kids. So I know that's your parents. They're like, it's not doing it right. I know. That's what happens. It'll happen to you, promise. Okay? Your kids will be like hovering or something, or transporting to other planets, and you're going to end up in the wrong solar system. Be like, sweetheart, where am I? I don't know how to get home. All right, so here's a laundry list of things that cause injury to the cell. Hypoxia. What is the definition of hypoxia? What's that? Lack of oxygen, low oxygenation. Reactive oxidative species, or too much oxygen. That's hyperoxia. We'll look at that. It's abbreviated ROS. Reactive oxidative species. Another name for it are free radicals. You've probably heard that, free radicals. And then you've heard of things that are free radical scavengers, right? Dietary things like blueberries. Everyone's really into blueberries because they actually kind of bind up these free radicals. And we'll talk more about that today. A variety of different chemicals, right? Anybody ridden an elevator in California? You're like, what? Have you read the sign? Yeah, like just being in the elevator, there's a whole list of chemicals that you're being exposed to that cause cancer. Yeah, that's California for you. Infectious agents like viruses, bacteria, fungal infections, immunological reactions, right? When the immune system goes awry. Genetic defects, you get an alteration in the DNA. Nutritional imbalances, you could have a lack of certain coenzymes or cofactors certain vitamin deficiencies like calcium or iron. Physical agents, just trauma, right? You get in a car accident, you bump your knee up against the desk, right? Tissue gets damaged, the cell gets damaged. Aging. So let me pause here for a minute. So I'll probably say this 17 times throughout the semester, but age is a pathology. So when you look at disease states, and if you're looking at it in an older population, like a geriatric population, there is an underlying disease that's in play. So if you look at our elderly, they don't heal as well. They don't recover as quickly. You know, they have a physically busy weekend. They're exhausted the next couple of days. They have stress in their life, family stress. That can cause a lot of issues, a lot of cellular injury. So aging is a disease process or a disease state. And it's really important to understand that, because if you're going to go into medicine and you're going to treat patients and you're treating pediatric or young patients versus geriatric older patients, like there's a huge difference between what works for one and what doesn't work for the other. Okay. So our first diagram, let's take a look at reversible versus irreversible injury. So there's two phenomenon associated with the inability to reverse the injury. Number one is you have dysfunction to the mitochondria. What does the mitochondria do for the cell? It creates ATP. It creates an energy source for the cell. No energy, the cell won't live. And we'll talk about that, more in a couple of slides. But real quickly, if you don't have ATP, what's one thing that the cell can't do? Just pick one. What's that?
Replicate DNA.
It can't replicate DNA. Create ion gradients. Glycolysis. Make proteins. I asked for one. You guys are classic overachievers. It's a room full of nerds. I love it. Okay. That's the first one. The second one is membrane disturbances. If the membrane is compromised, there's no return for the cell. Mitochondria and membrane disturbances. So let's first look at reversible changes that take place. Well, the cell is going to swell under injury. You're going to get the failure of active transport pumps. So you don't maintain these ion balances. And fluid homeostasis goes out the window. And it leads to what referred to as cellular swelling. The cell actually enlarges. You actually start getting what we refer to as fatty change. Fatty change as a result of toxic injury or hypoxia, where you have a metabolic injury and you start taking on a vacuole-filled cell with fat deposits. Some of those are supposed to go to the phospholipid bilayer, but your cell is traumatized, and so it's not doing what it's supposed to be doing, and you don't shuttle those transports of those lipid molecules to the cell membrane. So you get a fatty change. But these are reversible. You can actually recover from that. A normal cell will go through reversible injury on a regular basis throughout its life. Now, irreversible leads to what we refer to as cell death. So you can see here's a normal cell. You can see swelling that's taking place. You get some blebbing that takes place. You've got changes in the ER and the mitochondria. And if this continues with progressive injury and you lose membrane integrity, well, then you go down this pathway of necrosis. You get the breakdown of the plasma membrane, the breakdown of organelles, the nucleus, and you have cellular leakage that's taking place. Things that are supposed to be outside the cell come in, things that are supposed to be inside the cell leave. So this is a necrotic response. There's an inflammatory reactivity that takes place by your body, and it sends in inflammatory cells. Usually first it sends in cells called neutrophils, and then secondarily it's going to send in cells known as tissue macrophages. And we'll talk about those more probably Thursday, okay, but definitely next week. So this is the necrotic pathway of irreversibility. Again, the point of no return is when you lose the integrity of the membrane. That should make sense, right? That membrane, if you remember back to basic bio, that phospholipid bilayer is kind of one of the secrets to life. It separates things from the inside to the outside. It allows for ion gradients to be established, things to move into the cell down a concentration gradient. You work hard with ATP to pump certain ions out and certain ions in to create that influx of sodium when a channel opens. Do y'all remember that? So you get 3 sodiums that go out and 2 potassiums that come in on the sodium-potassium ATPase, which also takes energy, ATP. Okay, let's look over here on this pathway, normal cell. One thing I'm gonna point out to y'all, on the slides, they're all there, but each week I sometimes update the slides a little bit. This is a refreshed figure, so if your figure is a little blurry, the secret is if it's the file, the PDF file of the slides, and it has 2025 after it, then I've already updated it. And it's not that the old ones won't work, it's just they're kind of not as pretty, and some of them are in better quality here. Okay, so that's just, you can work ahead, but I just want to tell you if your slide deck isn't totally matching, because this one was a little blurry and I updated it. On this side, the normal cell process through a mechanism known as programmed cell death. And we talked about that Thursday. We introduced programmed cell death. We introduced apoptosis, where we actually don't have cellular swelling. We have condensation of the DNA material. It compacts. Remember the analogy I said is you start moving for the end of the semester, not May 1st to move out May 31st, or May 28th to move out, or May 30th to move out May 31st. You start packing at spring break. So here you're starting to organize the DNA material. Then the blebbing that takes place is shooting off little apoptotic bodies. And these apoptotic bodies have nicely inside of them packaged organelles and cellular material that can be recycled or reused. And so slowly over time, instead of swelling, you actually see a shrinking of the cell. And ultimately, phagocytic cells come in and engulf those apoptotic bodies, bring in a mitochondria, and now it has a new mitochondria. This is programmed cell death. This is non-programmed cell death. This is very organized. And what was the example I gave on Thursday about apoptosis not being a disease state always? The skin between your digits, right? Dying off and allowing for demarcation of digits. We'll look at another example a little bit later in the semester, but the example is in the immune system. You get apoptosis of unwanted B and T lymphocytes. So B and T lymphocytes that you make to fight infection, sometimes they're autoreactive and they react with your own body. And so you actually screen for that, and if you have a reactive one that's autoreactive, you program it for death. But the problem is, we'll flash forward, some of those autoreactive cells leak through, and that's where you get autoimmune disorders, like rheumatoid arthritis, right? MS, a lot of examples that are because of a leaky immune system where you didn't appropriately screen through apoptosis, and you have an immune cell that thinks your tissue is foreign, and that's the problem with autoimmunity. Questions? We good? Let me do one thing. I just want to double check my video. So, peace out. Okay, cool. Let's make sure I hit the button. All right, so let's look at cellular swelling. These are renal tubules at the bottom. Renal tubules at the bottom. And what we're taking a look at as we move from left to right is the morphological changes in the kidney tubule. Lower left is normal. These are simple cuboidal cells. They're organized. I think they look like pineapple slices. They're organized very specifically. And then you can see this disintegration as you move from left to right. And you start losing the cell membrane. You say disorganization of the renal tubule. Here you're getting the loss of the nucleus. So this is a classic example. As you move from left to right, the membrane's becoming disrupted. Now the membrane's gone. And you can kind of see how these cells are blown out with cellular swelling. So we call this hydropic change, for water content is changing. You get an internal vacuolar change. The internal vacuolar change is to house not just the water, but in the future, potentially extra lipid, that fatty change that I was talking about. It's reversible to a point. Somewhere in the middle slide, there's a point of reversibility. The far right slide, it's past that cutoff point. It's beyond the point of reversible. In an organ, you get many cells of that organ that are affected. Like in this particular example in the kidney tubule, this is early example of ischemia. Ischemia in a patient that isn't getting enough perfusion to the kidneys. Typically, this person's in like heart failure and they don't have enough blood pressure to make it to the renal arteries to perfuse the kidneys with blood. So when you start losing these cells, the organ itself may become more paler in color, like a blanched appearance. It's not nearly as perfused with blood. You get an increase in turgor pressure. That's the water pressure inside of the cell that forces the organelles up against the cell membrane and causes trauma to the organelles, right? So that causes damage and it perpetuates this loss of function of the cell. So ultimately, it's going to increase in weight. The organ will increase in weight. So at the gross level, the organ could be swollen, full of water weight, right? That's what a organ is a water swelled, or I just made that up. But I could have gone with it, huh? You guys would have believed me. Increase in weight due to this turgor pressure in compromising the integrity of the membrane. The cells themselves become replaced with these giant vacuoles. So let's continue down this theme of reversible. So any ideas of what this tissue is? Up top. This is the normal tissue up top. It is the liver. So you got the three zones, right? You've got the three zones. The central area of the lobule is the central vein. And at the periphery are the portal triads. You've got the three zones that function to supply different amounts of oxygen into the liver. So from the top slide of normal liver, you can kind of appreciate a liver that has necrosis happening. And what I want to draw your attention to on the bottom slide are these lipid-filled vacuoles. Do you see these giant open vacuoles full of fat? And this is often the fatty change or a fatty liver that takes place in chronic alcoholics. And you've probably heard of fatty liver disease and chronic alcoholism. That's what their liver would look like. We'll talk more about that in the liver and kidney section later in the semester. But another great example clinically of necrosis taking place. Now, there's a point of reversibility here to the liver. You've also heard, well, if the patient stops drinking, they actually can recover. The liver is actually a very regenerative tissue. Liver regenerate very, very quickly, okay? I think the design was so that you could make it through college, maybe, and not have second thoughts about things. But the point of no return is when there's scar tissue in the liver, all kidding aside, okay? I'm not advocating push your liver to its limits, but it does regenerate really nicely until there's scar formation in the liver, fibrosis of the liver. That's a cirrhotic liver, and that is beyond the point of repair. That's when you go on a transplant list. Okay, apoptosis. We're kind of shifting gears from necrosis, giving some examples of necrosis, some real world examples, some clinical examples that you can kind of, I think, connect some dots from just your life experiences or maybe your experiences in the clinic already. Some of you are CNAs and you're treating patients now. And which is what's amazing about this class is, you know, it's a very clinically focused class, but then a lot of you actually have more clinical experience than I do, right? I just play one Tuesdays and Thursdays, but you guys actually, some of you do this for a living. So apoptosis, this is that same picture from that previous slide. We can kind of start to see some examples of apoptosis. Classic characteristics, it's organized, very, very organized. You get membrane blebbing, where you form an apoptotic body that actually gets ejected out of the cell and can be recycled. The plasma membrane, most importantly, stays intact. It's preserved in an apoptotic process. In contrast with necrosis, the membrane it looks moth-eaten. It has holes in it. It's disrupted significantly. So apoptosis is a term, it's a Greek term, apo, from, and ptosis is falling. So it's like, it means like falling off, is it literally translates in Greek. So apoptosis is a Greek word that means a falling off, and it's referring to those apoptotic bodies. They're kind of like those, you know, emergency pods that are ejected out of a spaceship. You guys know what I'm talking about, right? And they put the person in there and they shoot them off, and then the ship explodes. So that's where this gets its terminology from. A German scientist, Carl Voigt, was the first to describe it in 1842. And many described it since then, typically using electron microscopy to be able to identify their findings. Because you can't really see this unless you're under high-powered magnification that you can get with electron microscopy. So examples of apoptosis that we've already talked about. We talked about the digits, the fingers and the toes, undergoing apoptosis to have demarcated digits. We talked about in the thymus, right? That's where T cells mature, and you have apoptotic signals to get rid of self-reactive T cells. There's also sort of a theory of nervous tissue in the central nervous system. So when you are born, you have all of the neurons in the central nervous system that you will have for the rest of your life, right? In the central dogma, that means the main well-accepted thought in the industry or the field is that central nervous system nerves don't regenerate when they're damaged, whereas peripheral nerves can regenerate to a certain extent. Okay, and some of you have had surgery, right? And you have surgery and you have an old scar, and you remember like when it was 2-3 weeks after surgery and you had your bandages off, you had like a numb area, right? And now that numb area has shrunk because those peripheral nerves regenerated, but there might still be an area that's still numb. So it's not complete regeneration. In a central nervous system, that doesn't happen at all. That's the reason that spinal cord injuries are so problematic. But around the concept of apoptosis, as we age, we have the die-off of nerves. And so, you know, we see this process happening through an apoptotic mechanism, not a necrotic mechanism. And so that's a third category, you know, kind of the if you don't use it, you lose it as you get older. And that's why a lot of geriatric patients are constantly trying to do mind games and Sudoku and playing Sudoku while they're doing pickleball or whatever, you know. So apoptosis, kind of 3 examples that describe apoptosis. So I really like this summary table. I don't remember what textbook I got this from. It didn't come from your 10th edition. It might have been the 8th, but it could have been another text altogether. But this just compares and contrasts apoptosis versus necrosis. So want to bet on one of the quizzes or want to bet on the exam, you're going to have some questions about, is this apoptosis or is this necrosis? Which of the following are characteristics of apoptosis? Which of the following are characteristics of necrosis? And I want you to be able to tell the difference, okay? So apoptosis affects single cells, not the entire organ, one cell at a time. There's no inflammatory response. You get cell shrinkage over time. Nice and organized. That's another one you could put up here, is organized in this little margin. You get the membrane blebbing, but the integrity of the membrane is preserved. You have increased mitochondrial membrane permeability, leading to the release of pro-apoptotic bodies and proteins that give rise to these like break-offs of these blebs that can be recycled by phagocytic cells. The DNA actually condenses in an organized fashion, and the apoptotic bodies are phagocytosed. In contrast with necrosis, it affects large amounts of cells. It could be the entire organ or a big portion of the organ. There's a significant inflammatory response because you have a lot of cellular debris. Over here, it's nice and packaged in a membrane, so you don't really have a huge inflammatory flare. You lose the membrane integrity, you get swelling of the cell, you get lysosome leakage, random degradation of DNA. It's not condensed or organized. And you get macrophages that come in and clean up the mess. And we'll talk more about those macrophages and inflammation Thursday and into next week. So let me pose this slide and ask you what we've already described and discussed. Maybe talk with your neighbor. Don't shout it out. Talk with your neighbor real quick. Which one is a picture of necrosis? And in contrast, which one's a picture of apoptosis? And if you answer that one with your neighbor, tell them why you say that. Okay?
Yeah.
What group has something notable to share? B is necrosis because the cell membrane is compromised. I would agree. Y'all can appreciate that. Looks like an old t-shirt that's just trying to hang on. Right? Moth-eaten. A, process of elimination, is apoptosis. What's a dead giveaway? The blebbing, the apoptotic body that's about to pinch out as it comes kind of right out at you. This structure right here looks kind of like an upside down pear coming like right out at you. Okay? So necrosis. Histology of necrosis. This is renal tubules that are pretty aggressive. We categorize this type of necrosis as coagulative necrosis, and we're going to get there here in a few slides. Just backing up to refresh, it's irreversible. You get nuclear damage. You can not see any nuclei here. And, you know, these renal tubules, you know, these sort of pineapple-shaped structures have no purple dots, no nuclei. They're gone. So again, this is a patient that is losing their kidney, you know, as a result of underperfusion of the renal arteries due to heart failure. And so they'll be in, you know, dialysis a couple times a week and on a kidney transplant list. It's usually bilateral. I mean, one will go first because one renal artery is a little higher than the other, and so it'll get a little bit more perfusion, but the second one won't. And everybody's a little different about which one has the higher or the better flow than the other. Everybody's kidneys are a little different size, right? Some your right kidney is a little bigger than your left. Usually it's because of the perfusion that takes place. So necrosis versus apoptosis. So now what we're going to do is we're going to start categorizing different types of necrosis. And this is extremely clinical. One category that is gangrenous necrosis is completely a clinical term. It's not even really used in the scientific literature. But because it's a clinical term and everyone's heard of gangrene, we talk about it. We kind of put it into its respective categories. So the first type of necrosis, so now you understand that we're not dealing with apoptosis, we're dealing with necrosis. The first type is called coagulative. Now, coagulative necrosis affects certain organs, like the kidney, we just mentioned that. It also affects the heart, the adrenal glands, and it leads to these wedged, like infarcts, or wedged. So here is the organ, the adrenal gland, and you can see this wedged infarct. This is an older one. This is a newer, fresh infarct. Here's another fresher infarct that are taking place. Here's the remnants of another old infarct. And the reason it leads to a coagulative type of necrosis in these specific organs, like the kidney that we just saw histology on, is because of the way the blood vessels enter into the organ. So the blood vessels kind of make a tree as they enter into the organ, right? And so if you have an obstruction, you're going to get an infarct that covers the area that vascular tree would have perfused, which has the shape of a wedge. So coagulative necrosis in the heart, this is heart scarring after an infarct, after a heart attack, where they have a blockage of the vessels perfusing the heart. And it leads to these classic wedge type shaped infarcts or coagulative type of necrosis. Another organ that's affected by this that can go on the list is the spleen. And I misspoke, backing up. This is actually a splenic gross view, not, I think I called it the adrenal gland. This is the spleen. So you get protein denaturation that's taking place that's secondary to acute ischemia. So acute ischemia is a loss of blood flow, like what we see here that I just drew out. You lose that blood flow of that perfusing vessel. And ultimately, it leads to fibrosis, which is just another name for a scar. So you've heard this play out, like you get a phone call, mom or dad, everybody's upset, grandma or grandpa's in the hospital, they had a myocardial infarction. Unless your parents are physicians, they probably said a heart attack, okay? And I say, what, but sounds like he's stable. We've talked to the doctor. They put a little stent in. He's recovering, and we don't know right away, but they don't think there's a lot of scarring. So they think he's going to be good. So what they mean is there's not a lot of this fibrosis. This is scarring. That means that the tissue isn't lost. We haven't lost functionality of that heart tissue. And so you want to reperfuse the organ as quickly as possible. That's why you put a little stent in there to reopen it. Make sense? Okay, so let's look at some of these examples. This is kidney. This is coagulative necrosis in the kidney after a kidney infarct. Here's what the normal histology looks like of a kidney. Here it is side by side. So you see normal on the left, infarcted kidney on the right. And what I want to bring your attention to back to 202 is, so these structures are the glomeruli. Remember those structures? And do you see how these are like, everybody moved out. They're like closed up and darkly stained because they're all dead. So that's an infarcted kidney. Okay, next up, liquefactive necrosis. Liquefactive necrosis tends to take place in central nervous system. Brain cells, where they're neurons and glial cells of the brain, they have a lot of hydrolytic enzymes and lipids, and they have very little connective tissue. So you end up getting a degradation or a digestion that sort of liquefies the soft tissue and then is walled off by like a cyst. And so you can see in this patient's upper left temporal lobe, your right side, here is a liquefactive necrotic lesion after a stroke or a cerebral infarct. Okay, very, very different because of the type of cells that are being affected and the propensity of hydrolytic enzymes that kind of breaks down the tissue and makes it very soft as it digests. So the characteristics of these, they're irregular. They're not wedge-shaped. They're irregular. They're roundish or ovoid, but they also have irregular borders, and there's often an empty space on the tissue slice when you do histopathology because there's not a lot of tissue integrity to hold the tissue in place. So when you do histopathology, you dehydrate the tissue and then you replace it, all of the spaces within the tissue with wax. And then you embed it in a wax medium and then you slice it. So it's going through wax, tissue, embedded in wax, and then wax again. So if there's not a lot of structure in the tissue, a lot of times that tissue will pop out of your section. And so you get a lot of, hematoxylin, eosin stained sections that have a lot of like shredded tissue because there's not a lot of integrity to this. The process itself is a very slow healing process. It creates a scar. It's called the gliosis because it's glial cells that actually do the cleanup. They're actually microglial cells in the central nervous system. If you remember back to 201, those are the like macrophage-like cells in the central nervous system. We also do see this type of necrosis in a pyogenic infection. So this is a bacterial infection that makes pus. And because of the pus formation being a result of hydrolytic enzymes from the leukocytes, you end up getting like an abscess. And histologically and clinically, we refer to it as a liquefactive type of necrosis, very much like what you see in the central nervous system. Next up, caseous necrosis. This is probably the most disgusting in my opinion. All of these smell to high heaven if you have an opportunity to smell them. You're like, why would you smell them? It's like, I don't know. Why wouldn't you, right? You're like, oh, I wonder what it smells like. They stink. They really stink bad. Caseous necrosis is like a combination. It's a combination of coagulative and liquefactive. You often see this in tuberculosis infections, where the necrotic cells disintegrate, but they're not digested completely, and it gets walled off. So you kind of get some defined borders. It's not wedge-shaped, but inside the middle, it's more like a cheesy consistency, like a soft cheese. Like think of like a soft Gouda type of cheese. Okay, not talking like a Havarti. I'm talking like kind of a soft cheese. Some of you that are thinking about having a cheese and crackers later, you're gonna pass on that one. So tuberculosis is often the culprit, and you can see on the top image, this is a lung with caseous necrosis, kind of this cheesy appearance in the middle. And this is a tuberculosis infection. The bottom right image, you can see a lymph node that's been infected with tuberculosis. So it's got that yellow kind of defined border. It's not wedged, but in the middle it's really soft, mushy, like liquefactive. And a fibrotic scar on coagulative is harder than the surrounding tissue. Does that make sense? So that, like, why are you talking about soft cheese? Well, the consistency of the infarct or the necrotic tissue gives it more of a liquefactive like touch versus coagulative, which is harder and more dense than the surrounding native heart tissue, splenic tissue, adrenal gland, etc. And then in the middle, we've got a chest X-ray. And what you're able to demarcate is the formation of the infection, right here with these black arrows. You see this little black spot right here in the right lung. And so that's what you're being able to see under imaging. So tuberculosis or TB, it's a pretty widespread disease. It's a mycobacteria, and it's transmitted. It's airborne, coughing, sneezing. It's very very high death rate, or mortality rate's very high. Usually the patients have sputum in the end stage, or phlegm that comes up with blood, because you have this really dramatic infection in the lungs. And this is the disease that Doc Holliday passed away from. If anybody remembers kind of the Wyatt Earp storyline, Doc Holliday. My favorite Doc Holliday was by the late Val Kilmer. If you've ever seen the Wyatt Earp with Val Kilmer as Doc Holliday, I think he portrayed this really well. But you'll see that character that he portrays in that sort of old Western remake with tuberculosis. He nails it. It's exactly what you would expect a TB patient to pass away and kind of look like. So a combination of coagulative and liquefactive. Questions? Talked about 3 different types of necroses: coagulative, liquefactive, and now caseous. You ready for the next? Fat necrosis. So fat necrosis is rather interesting. It affects tissues that have a lot of adipose consistency to them, like breast, pancreas, other abdominal organs. And you get cellular dissolution due to lipase activity that's being released. So if the tissue gets damaged or traumatized, or if it is injured, or there's a pathology associated with, like, the pancreas, and that's what you're seeing here in this image of fat necrosis, is pancreatic acinar cells releasing lipases and them actually creating these little pieces of stone. So what this is in this organ, the pancreas is highly consisting of adipose tissue. The lipases break down the triglycerides in the tissue, and then the free fatty acids, they bind with calcium, magnesium, and sodium, and it creates a mechanism or a process known as saponification, which is actually how you make soap, like bar soap. So these little stones have the consistency of like ivory soap, and they're hard, and they're much harder than the surrounding adipose tissue. So imagine if this is a self-exam of a middle-aged or older woman, and they feel a lump of some sort. The number one misdiagnosed breast cancer on self-exam is fat necrosis. Remember, age is a pathology. Like, why are they getting this? Well, because they're getting older, and their tissue is not healing as well as it normally does. It's what causes cell. It's one mechanism that causes cell injury is age. We talked about that. So under self-exam, these women make appointments. They get imaging. Under imaging, a lot of times this will light up as a dense material, right? And now they're more worried, so they do a biopsy and confirm histologically that they're clear. That with family history, medical history, they take this all in consideration. But that's kind of gives you an idea of how that like talk track will go with that particular patient. Can this lead to cancer cells, developing cancer cells? If the breakdown of necrosis gets aggressive enough and you have a lot of inflammation, and we'll talk about this in the cancer lectures. So chronic inflammation can start to create problems at the level of the DNA, and you can cause mutations in a cell. And if you cause a mutation in a cell where it won't stop dividing, then it becomes cancerous. So to answer your question, yes, potentially, eventually, takes years, takes a lot of pathology of age, and it doesn't always lead to it in every patient. If that's in combination with, a pre-existing genetic family history of a lot of, breast cancer in women in that family, then yeah, a lot of women now are kind of being very proactive about, looking at their family history and making decisions in certain parts of their life about, kind of getting in front of it, basically doing double mastectomies early. It's much more prevalent these days because we have a lot of tools now available from genetic screening as well as family history and putting those two together. Okay. All right, here's our gangrenous necrosis. So the gangrenous necrosis, I kind of mentioned earlier, it's really a clinical term. There's three types that I want to describe. There's dry gangrene, there's wet gangrene, and then there's gas gangrene. And they're all kind of distinctly different. But, typically it's on the extremities. So it happens a lot in skin, like on the fingers and toes. In extreme cold, you'll lose blood flow to the distal extremities. The blood flow creates a hypoxic environment. You starve the tissue of oxygen and nutrients, and it goes through a necrotic process. Okay, so why isn't it called coagulative necrosis? That's a great question. That's why it's a clinical term, right? Because when you see it, it's usually on fingers and toes. It's on the extremities. So gangrenous necrosis kind of gets its own category. What happens after the hypoxic injury, you get a lot of bacteria that invades the tissue. And the dry gangrene is what you're seeing here, is a result of a coagulative necrotic mechanism. So dry gangrene is really coagulative necrosis. The tissue shrinks, it's either black or brown. Wet gangrene is when neutrophils invade and you get a liquefaction type of necrosis, usually in internal organs. You get a lot of swelling. The organs will be cold, they'll be black, they'll have pus, a foul odor. So wet gangrene is a liquefaction type of necrosis mechanism. So again, why is it called wet gangrene? I don't know, because the clinicians want to name it something specific. So, right? You see what I mean by a clinical term? But mechanistically, it tracks with liquefaction necrosis. Gas gangrene is a specific type of bacterial infection known as Clostridium. So it's an anaerobic bacteria that releases a lot of toxins and hydrolytic enzymes, and those actually break down the connective tissue and create gas bubbles. That's gas gangrene. So a couple of histology slides. Normal skin on the left, and then the area in the box that's zoomed in is the area that we're capturing in this example. But what's shown on the right is the necrotic dermis, not the normal dermis. Does that make sense? So this is the skin gangrene, but it's coming from this particular area in the dermis. And what I want you to see is just the propensity of inflammatory macrophages that have invaded. A lot of neutrophils as well, but now you're in this granulation tissue where you've got tons of inflammation happening. In fact, in the lower right down here, it looks like you've got some foreign body giant cells that are starting to collect. Foreign body giant cells are a bunch of macrophages that fuse when the infection or the foreign object is so aggressive. Probably a bacterial infection now at this point. And we'll talk more about inflammation, like I said, Thursday and into next week. but kind of giving you a little prequel to what's coming. Questions on the types of necrosis? With ischemia, dry gangrene, yeah, usually it's a loss of blood flow. That's what's going to trigger dry gangrene, right? I mean, a lot of people think it's, why is it cold weather? I thought it was cold weather. In the movies, it's always cold weather. They pull off their boots and their socks and like, oh my gosh, your toes are gangrenous. Well, it's because the cold weather restricts the blood flow to the distal extremities. And so that's what's happening. That's why the toes are so cold. There's no blood flow. It's also like minus 40, but there's no blood flow, okay? I've seen all those same movies too, man. Okay, we're going to get into some of the mechanisms now. All right, so this is a good time for you to take a little bit of a stretch, a little bit of a break, because it's going to get a little bit more mechanistic and in detail, okay? This might be the section that you kind of need to rewatch. Can you check my feed? Am I still recording? Still counting? Awesome, thanks. So I want to talk about the principal mechanisms of injury. I really like this like sort of flow chart because I think it really helps to paint the picture of all the different things that are happening when a cell becomes injured. So you have some sort of injurious stimulus. Now, some of the stimuli that we've been talking about are like hypoxia, lack of blood flow. But you can insert really any of those lists of injurious stimulus, like age. In old people, this does happen. Okay, in your older patients, this happens. So when you have an injurious stimulus that damages the membrane, hopefully you can appreciate when the membrane gets damaged, the plasma membrane is traumatized. You have a loss of cellular components. You impact the lysosome. It releases enzymatic digestion molecules that break down cellular components, and you compromise the mitochondria. You compromise the mitochondria, you lower ATP. You lower ATP, we'll get there, but there's multiple downstream events of lowering ATP. We talked about some of them, right? I asked for one example, you gave me 4. Protein synthesis, right? DNA repair, formation of energy. You also damage the cytoskeleton on some of these injuries, and you damage the DNA. If you damage the cytoskeleton, you actually lead to membrane damage, which ultimately leads to all of this, which kind of triggers the whole cascade of events. Now, over on your far right of the slide, you can see when you impact the DNA alone, you can actually go through only apoptosis, and this is your body's way of trying to evacuate early. So when the DNA is damaged, a lot of cells will go through programmed cell death, apoptosis, so that you minimize the extent of the damage, you don't propagate a mutation, and you save as many of the inside parts of the cell as possible. So really the only way to go through apoptosis is you signal DNA being compromised and the cell's mechanism say, okay, I need to trigger apoptosis. Let's not let any of this stuff take place. So this is sort of our roadmap of where we need to be. Now, when we look at cellular response, there's a couple of different things on this slide. This is an atypical cell. Cut down the middle is this cell, for example's sake. On the left side is an autophagic response in that cell, and on the right side is a heterophagic response in that cell. Okay, so it's one cell, and it's using one cell to describe what could happen in 2 different circumstances. Does that make sense? Otherwise, it could be kind of a confusing picture. So it's just for illustrative purposes, because here's the nucleus. Autophagy, where you've got a response to injury where the primary lysosome is going to ingest the damaged organelle in an autophagic vacuole, break it down, and exocytose it. The cell takes care of it on its own. It cleans up its own housekeeping. Heterophagy is this cell now has ingested a particle from another cell, potentially an apoptotic body, or it could be cellular debris if this is a macrophage cell. You have a phagostic vacuole, you get a phagolysosome, you break it down, and you exocytose it. So the cell can do it to its own parts, or it can do to a neighboring cell. That clear? You tracking with me? Okay. So in autophagy, it's a catabolic response. You degrade your own cell's componentry. And in heterophagy, it's a substance that's taken from another cell to recycle those parts. Now, the cellular response is very dependent on three things. What type of injury is it? How long did it last? And what's the severity? The autophagy is on minimal injury, short-term damage, short-term responses, minimal severity. That's autophagy. You may actually see increased size of the smooth endoplasmic reticulum because you're trying to crank out more metabolic products to help facilitate what's happening, right? You're packaging more things. You're transporting more things. You're recycling more things. The mitochondria activity goes up, becomes altered because you need more what to make this happen? ATP. You need more energy, right? This is kind of an all hands on deck type of thing. And then you go through what we refer to as cytoskeletal changes because the cell is going to be maneuvering. It's digesting something. It's deciding, am I going to keep it inside and recycle it for me, or am I going to dump the particles out? And so the cytoskeleton is going to change as the cell kind of maneuvers to figure out what does it want to do under that circumstance. So in hypoxia, back to my kind of classic example I keep using, renal tubules, normal up top, under coagulative necrosis on the bottom. So the causes here, typically hypoxia, due to ischemia of the tissue or low oxygen. You're going to get chronic adaptations that take place, like long-term adaptations. You'll lower metabolic rate of the organ. You'll decrease the number of organelles inside of the cells in that particular organ. And then acutely, you're going to see necrosis because you don't want to lose the whole organ right away. So you'll have necrosis that's kind of punctate. It's in certain regions as the organ is starting to lose the battle, if the insult of chronic ischemia continues. So the picture here, again, another heart failure patient. This is called acute tubular necrosis, is the terminology. Acute tubular necrosis, ATN. And, hypoxia, low oxygen levels, is the cause, leading to ischemia, which is low, blood flow into the tissue. And you lose the integrity of these pineapple-shaped tubules as they sort of disintegrate. You can still make out some of them here. There's one right down here, but this one's blown out. This one's totally blown out. This one's so blown out, it's lost a lot of the nuclei. Again, it would look like a coagulative type of necrosis due to a hypoxic situation. So how does this happen mechanistically? So let's start at the upper right of this slide. Upper right, you've got a blood vessel that has a blockage, an occlusion. So that occlusion right here in the darker color is not allowing blood flow into the tissue, kind of like what I drew over here. So the mitochondria don't get oxygen. If the mitochondria don't get oxygen, why is that a problem in a cell? You lose the ability for the mitochondria to do what if they don't have oxygen? Make lots of ATP. The cell can still go through glycolysis in the cytoplasm and make some ATP, but aerobic respiration is where you make most of the ATP for a cell. Do you guys remember this? So this is why it's relevant. Am I going to test you on how many ATP do you get from one crank of the Krebs cycle and the electron transport chain? I won't. You already had that. But is it 2 ATP net or is it like 36? Which one is it? It's 36, right? You guys remember that? You get way more ATP out of aerobic respiration. Aerobic means with oxygen. So if you don't have oxygen, you lose the ability for oxidative phosphorylation. You lower your ATP levels. That's why you learned that. You didn't know that, but that's why you learned that. Because if you drop your ATP levels, you compromise your sodium pumps. You compromise your sodium pumps, you get an influx of calcium, water, and sodium. You get an efflux of potassium, and you get endoplasmic reticulum swelling, cellular swelling, and loss of microvilli blebs, all because of the sodium pumps not working. You lose ATP, you increase anaerobic sources of ATP. Anaerobic glycolysis goes up because the organ is trying to create ATP to survive. If you increase aerobic glycolysis, you drop your glycogen stores because that's the fuel source you're using to make glycolysis happen. You increase lactic acid, and so the pH drops, it becomes more acidic. If it's more acidic, it damages the DNA. Right? Because that's a lot, Keller. Like you're saying, I'm just reading the slide, man. That's all I'm doing. You could do the same thing. See ATP here, go this way. See what happens. See ATP here, go this way. See what happens. ATP this way, no ATP. You detach ribosomes. You detach ribosomes. Somebody said it over here earlier. Protein synthesis is compromised. So no blood flow, no oxygen, very bad for the cell. Does that make sense? Like this one slide has so much information in it. This is a great tool to study with a study partner and say, like, do you understand this? And if you don't, come see me on Monday in office hours. You can be on Zoom, and I'll walk you through this slide, and we'll back up because that's a lot of old stuff that I just threw at you from like 201, 202 about sodium, potassium pumps and anaerobic glycolysis. Aerobic respiration, which is another name for oxidative phosphorylation. You could write here in parentheses, aerobic respiration. That's another name for it, if you don't remember that. So the decreased mitochondrial activity lowers what? Goes in the blank. Lowers ATP levels, right? That's the whole takeaway from this slide is you've lost ATP. Okay, so calcium, I said here, you get an influx of calcium, water, and sodium, and an efflux of potassium. Why is an influx of calcium bad? So this is the next step mechanistically of the problem. When you've got necrosis happening and you lose blood flow to an organ, or you have a necrotic response happening, if you get a lot of extracellular calcium inside of the cell, like from some injurious agent, go back to this slide, it's right here, you just lose ATP, so the pumps fail and now calcium is coming in. You've got an increase in cytosolic calcium, and look at all of these enzymes, ATPases, phospholipases, proteases, endonucleases. Calcium activates all of these degrading enzymes. Calcium activates all of these degrading enzymes. So you break down ATP, you break down your phospholipid, your membrane, you break down the cytoskeletal proteins, you break down the nucleus and the chromatin damage, all because of calcium. So it's like a snowball effect. You guys see that? So calcium infiltration, very bad. Loss in ATP, very bad. That's what starts it. Now let's look at reactive oxygen species. So if we've got a situation, you see oxygen up at the top here, you're in the mitochondria, and you can sort of see this reaction that's going from left to right. So this reaction from left to right is you take oxygen, and if you hit it with some kind of injury like inflammation or radiation or chemicals, Reperfusion injury is what happens when a tissue loses blood flow and then it receives blood flow back again. This creates an unstable oxygen bond. You get a superoxide. This superoxide makes hydrogen peroxide, and in the mitochondria, this Fenton reaction creates these hydroxyl radicals or free radicals. And this is your reactive oxygen species. Now, fortunately, we have mechanisms to deal with this. So we've got 3 different mechanisms to deal with this. We've got antioxidant mechanisms like superoxide dismutase that's in the mitochondria, SOD, and that takes this O2 free radical back into H2O2, puts it into hydrogen peroxide, and keeps it there more stable. You've got glutathione peroxidase, also found in the mitochondria, that takes the OH free radical and puts it back into the H2O2. And then you've got the catalase that are in peroxisomes that take these 2 intermediates and push them into water and oxygen. So those 3 mechanisms usually do a good job of cleaning things up for us. But when the system gets overrun and this can't keep up, you have reactive oxygen species that are still present. Unfortunately, what results is you get oxidation of everything. That's what the free radicals do, is they start to oxidize fats. They oxidize proteins. They oxidize DNA. If they oxidize fats, then they disrupt the plasma membrane organelles. If they oxidize the proteins, you lose their enzymatic activity, so they're non-functional proteins now. And if you oxidize DNA, you lead to mutations. And if you lead to mutations, per the question in the back of the room, over and over and over again, that could be a cancer state. So this is why ROSs, reactive oxygen species, are bad. They're not good for us. So if we look at an example of detoxifying and causing trauma to tissue, this is one in pediatric medicine that's unfortunately a little too familiar. And this is Tylenol overdose. Acetaminophen is the active ingredient in Tylenol brand medication. Wonderful drug. Think the world of it. But one of the most common overdoses in kids. Unfortunately, it's typically because of well-meaning parents. So they'll give the kid like a cold medicine that has acetaminophen in it, and it's like a all-in-one. It takes care of the runny nose. It takes care of their fever. It takes care of their cough. Makes them smart. Keeps them from fighting with their sister. Okay, kids chill, and then in the evening they give them kids Tylenol. And they do that too much. And this is the liver, healthy liver upper left, necrotic liver lower right. So what's going on with acetaminophen and getting into a necrotic liver is the hepatocytes are very, very sensitive to acetaminophen toxicity. And so acetaminophen is metabolized in 3 different pathways. So pathway number 1 is it's conjugated to sulfate. Pathway number 2 is it's conjugated to glucuronide. And pathway number 3 is it's metabolized by cytochrome P450 oxidase. Now, the first 2 processes, sulfate and glucuronide, account for about 90% of the dosing or the metabolism and the detoxifying of acetaminophen. The other 10% happens through this cytochrome P450 system. And there's an intermediate, N-acetyl P-benzoquinone amine, NAPQI. And that molecule, this NAPQI, is a hepatotoxin. It's toxic to hepatocytes or liver cells. And so when it's taken in therapeutic doses, then the NAPQI levels don't really get too high. But when you take too much of it and you have too much of the intermediate, you end up destroying the liver. Okay? Questions? In the last little segment, we just have a couple of slides of material that talk about cellular infiltrations. So we've talked about all of these: water, lipids, glycogen, proteins. I'm going to talk about pigments next, okay? And in the pigments are hemosiderin and lipofuscin. So hemosiderin is the uptake of iron. And iron is found in the blood, in red blood. And this one is shown in the upper right and the lower left. This lower left is a Prussian blue stain. And you're seeing hemosiderin amounts in the liver tissue that is present in the cytoplasm of hepatocytes. And ordinarily, there'd be a small amount of hemosiderin in the liver, but in this particular patient, there's an excessive amount. The upper right is also a liver image showing a different type of staining of hemosiderin. And what you're appreciating is kind of this yellowish streak of the hemosiderin, kind of an indication that the liver has a little bit too much bruising in this particular sample. Lipofuscin is caused by the breakdown of organelles, and it's considered like an aging pigment or an example of wear and tear. And so this is the heart, and you can see kind of like this stain here, but this lipofuscin is the breakdown of heart tissue as a patient gets older, and just is indicative of the age of pathology. So last for today, let's talk about calcium accumulations. And there's two different types. There's dystrophic and metastatic. Now, metastatic is not referring to cancer. It's referring to calcium accumulations. But dystrophic is found in dead and dying tissues. You'll see dystrophic like with atherosclerosis. You'll see it with tuberculosis patients and in heart valves. The picture that you see here is a dystrophic aortic valve. And you can see all of the calcium accumulations. It looks like hard water accumulations, which is calcium on your faucets in Phoenix, right? Happens here too, but it's like more aggressive in the valley. So this happens as the calcium kind of finds its way and deposits in the particular patient, over time. The metastatic is usually due to some type of metabolic process. So it's referring to metastatic, meaning a metabolic abnormality, like hyperparathyroidism, hyperthyroidism, hypercalcemia, Addison's disease. So again, in a lot of dystrophic examples that we'll look at pathologically, they'll look like this aortic heart valve. Metastatic is a metabolic problem, okay? So one parting question for you today. The gross appearance of the myocardium shown here from a 58-year-old man who is admitted with chest pain is most consistent with which of the following microscopic changes? Liquefactive necrosis, caseous necrosis, fat necrosis, coagulative necrosis, or apoptosis? What are the takers? Who's got an answer for us? D, coagulative necrosis. Why coagulative? Because of the shape of the scarring, and also it's one of those categories on the slide of coagulative necrosis: kidney, heart, spleen, adrenal glands, right? So if you can't appreciate the wedge, it's heart, it's, if I had a picture of central nervous system brain, it would be what kind of necrosis? Liquefaction. Very good. All right, have a great evening. I'll see you all on Thursday.